Friday Forum. Health is Wealth, the webinar series, which is starting today. Let us start with the Qiraat from Yaqub Zakaria. Yaqub, yeah.
Assalamualaikum warahmatullahi wabarakatuh. My name is Yaqub and I'll be reading Surah Tariq. أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. والسماء والطارق وما أدراك ما الطارق النجم الثاقب كل نفس لما عليها حافظ فلينظر الإنسان مما خلق من ماء دافق يخرج من بين الصلب والترائب إنه على رجعه لقادر يوم تبلى السرائر فما له من قوة ولا ناصر والسماء ذات الرجع والأرض ذات الصدع إنه لقول فصل وما هو بالهزل إنهم يكيدون كيدا أكيد كيدا فمهل الكافرين أمهلهم رويدا.
Thank you, Yaqub. So let's go on with the presidential address. Let me invite our Honorable President, Mr. Shabir. Please take over.
Assalamu alaikum. Good afternoon to all. Warm welcome to yet another Friday Forum program. So happy to see you all once again. By the grace of God, the pandemic situation is slowly improving, but still to be cautious. And people have started flying back from India. And for Friday Forum, this is going to be action time. We have already planned a couple of programs, and those programs in pipeline, we will start shortly as per schedule. Inshallah, shortly we'll be having another presentation next week by Dr. Jafar Ali on the topic Campus to Corporate. Then we'll have a kids program in association with the Children's Day in November. And hopefully next week, we arranged an outdoor activity for our Friday Forum juniors. Now coming back to today's session, this is going to be the first presentation of the series of talks on the topic Health is Wealth. I'm so happy and excited today as the speaker. Dr. Sajid is my friend and classmate in MES Raja Residential School, Chathamangalam, Calicut. I'm sure this is going to be a very interesting, informative and enlightening session for all of us. So we need to stay tuned till the end to get the best out of it. Thank you all once again for joining this program. Jazakallah. Over to you, Zikr.
Thank you, President Mr. Shabir. I think it's really a great feeling, to see everybody back. I think our last program was 2-3 months back, since we have been regularly doing a lot of programs, and after it's been a big gap that we are coming back. And as Shabir said, since quite good news being seen overall in Kuwait, considering the slow improvement in the market, everybody getting vaccinated, and the economy also showing a little bit boom in Kuwait. It's let's all hope that very soon we can have more offline meetings. But nevertheless, at least with online meetings, I think now that we have opened up with a series of talks on health, since we had been doing a lot of sessions in the past, like children's program and Islamic programs. Now it's good to see the doctors team or the medical team back. And I think the medical or doctors wing of FridayForum is really gearing up with a lot of programs, a lot of orientation programs coming up in the medical sector. So now, by the way, the topic for today is about diabetes, bitter sweet symphony. This is a topic I'm sure a lot of people will have a lot of doubts on this topic, because especially diseases like diabetes and thyroid, these are some of the things which, some of the diseases which are proving out to be so common in our community these days that, doctors would say that, this is, yeah, you have a thyroid, you have a diabetes, you will have to have a lifelong medication, insulin, you will have to keep on going. So is it all that true? And, sometimes it gets so vulnerable that, you might have to, cut parts of your organs, like cutting your legs and all, when the infection spreads. So, is it all to do only about sugar consumption, or is that anything to do with sugar consumption? A lot of doubts remains, So anyway, to understand more about it, to clarify all our doubts, and to have a better understanding of this topic, which is a big issue these days, let me take this opportunity to welcome Dr. Mohammed Sajid. Let me also take this opportunity to welcome all of the FridayForum members, the alumni members, and the guests who have joined here to attend the program. Before we go to the talk session, let me welcome Dr. Mohammed Siraj to give a brief introduction about Dr. Sajid. Now, Dr. Siraj is a registrar in cardiology in Chest Disease Hospital. So, Dr. Siraj, please.
Assalamu alaikum all.
Alaikum salam.
And I'm very pleased to have a brief introduction about today's speaker. He's an distinguished, eminent speaker, teacher, and a doctor. Actually, he's hailed from our native place, and he studied from the same school where I studied. He was my senior. Actually, me also studied in the MES Raja Residential School, Chatlamangalam, Calicut. I was a junior for him. Later, he moved to Pioneer College and Talipuram, Sajid College from Talipuram, where he has 3 graduation courses. Then later, he moved to Al-Amin Medical College, Bijapur. After he just joined to Transplant Medical College, where he had studied, and later moved to UK, London, where he started training. He got trained in MRCP. Then he started practicing in multi-speciality hospitals in various parts of UK. And later he got trained, took his FRCP, that he became consultant and in Diabetologist and in Endocrinology mainly. And got then later he practiced as a consultant in Endocrinology and Diabetology in various parts of UK. Then later he moved to Abu Dhabi, and he started working there, and he is a tutor for diabetic programs, and he's a writer. He wrote many books, I think, on diabetology and endocrinology, and he's an MRCP tutor, examiner, and he taught many students, the grad and postgraduate students. He taught in diabetology and endocrinology. I get this opportunity to welcome him on behalf of myself and all the entire family of FridayForum Kuwait. And it's a very nice pleasure to meet him to give a topic on, especially on diabetes, because as you all know, this is the silent, diabetes is the silent killer for the 21st century. Because as a cardiologist, I met, it's like cardiologist and diabetologist like go with each other. If you don't like, if you don't control his diabetes, you can progress his coronary artery disease. That means they are so close together. So I also like to to see what's his new advice and management what on this topic. Okay, once again, I thank each and everybody and welcome each and everybody for this program. Thank you all. Assalamu alaikum.
Thank you, Dr. Siraj. So, mashallah, very qualified and well-experienced speaker today. So over to you, Dr. Sajid.
Assalamu alaikum and good afternoon to everybody. Thank you for that kind introduction. And while I start sharing the slides, I'll probably quickly, briefly talk about the things I'm going to talk about today. First of all, thank you to the FridayForum, the Kuwait chapter, for inviting me over. And I would also like to welcome everybody who's taken their time off on this precious off day to join us. Now, I'm going to talk about diabetes. I'm deliberately named Bittersweet Symphony, not just because of the hit song Bittersweet Symphony by Verve, if you have heard of it, but more than that, diabetes is all about sugar and being sweet, but deep down under, it can be quite bitter if not dealt appropriately. So without further ado, I would just proceed with my next slide. This is just an overview of what I'm going to speak about today. Just be talking about the physiology, pathophysiology, and how kind of diabetes comes into play and the regulation. And there are various types of diabetes, as somebody's already mentioned earlier, regarding the different medications being used and how and why, and the treatment options and complications, of course. And in the end, I'll talk briefly about technology. Now, some of you might find this quite simple. Some of you might find something new. The difficulty of giving a talk to a group like yours is you have got a mixture of everyone. You have got doctors, you have got qualified professionals, you have got quite a few people from different fields, and pitching it right to this group is very difficult, because if it's a specialist group, I know where I need to go. So I've made it kind of a bit simple and more picture kind of talk rather than bullet points, to make it kind of friendly and to avoid or prevent you from going to sleep. So some of this might be simple. Bear with me if you find it, these information you already know, but I'm sure you'll all find something useful from today's talk. Now, going on to the next, moving the slide, to be honest. Okay. Right. Now, diabetes mellitus. What is diabetes mellitus? Right from the word go, the diabetes means siphon, or to pass through. And what it means is, in common term, passing water or passing urine. And mellitus means honeyed or sweet. So essentially, it all means passing sweet urine. The Greeks found this out, and you don't really need to explain how they found out sweet urine. The only way to do that is by tasting it, obviously. So that's probably how they found out. And the diabetes is all about three things. It's about sugar, insulin, and the way the insulin acts in the cellular in the body. So this is a chronic condition, as some of you already mentioned, and it's all about how food turns into energy and how the energy is being used up in the system and in the body, how it takes up. So the top picture, I've put two cartoons there. One on the right is about the glucose, which you probably, most of you would have seen in your biochemistry class. And to the left is the pictogram, is a 3D pictogram of the insulin molecule. And below that, you have seen, what you see is a pictogram of a cell wall, and you have two receptors there. One is the insulin receptor, the other one is the glucose 4, which is called a GLUT4 receptor. So what happens usually is the insulin will come and attach to the insulin receptor, which makes the glucose pore open up and the sugar goes inside the cells for it to be utilized. And this is the basic of most of the problems with diabetes. If there is a problem with insulin, with the glucose transport, or within the cell wall, how it gets in, that's all basically what diabetes is about. And we'll go a bit more detail in how things happen. So before we talk about diabetes, what I would talk about is what happens when you eat food and how bad glucose is usually maintained, the normal homeostasis. So when you eat food, I don't know if you can see my arrow, I hope you can. When you eat food, the food gets absorbed and it gets broken down initially in the stomach and then it gets absorbed and it comes into the system. When it comes into the system, there are a lot of hormones that is being secreted. One of them is insulin, which comes into play this way. And there is a lot of other hormones, some of them which we will discuss in detail later on. So once the sugar gets absorbed, the insulin, the pancreas get activated and starts secreting insulin. What insulin does is it acts on different parts of the body. It acts on the muscles and other organs where the sugar is taken up and utilized. It acts on the liver by storing the excess glucose so that when you need it, it's broken down back and utilized as glucose. It also acts on the fat where it deposits and increases the fat storage. And it acts on the other organs, including brain, where it needs insulin for the proper uptake of glucose. So this is the normal, what happens in normality after you eat food. And when you come down to on the left, the cartoon, it's basically how the sugar is maintained. It's all a balance between the pancreas, the sugar, and the other organs. And the balance is maintained by, initially when you eat, the sugar goes up, pancreas secretes insulin, and then the insulin acts on the liver to decrease the blood glucose, acts on the organs for the increased uptake of the glucose, and acts on the fat for further deposition, and the sugar is brought down. And when you sleep or don't eat or fast, and when the sugar goes down, the insulin secretion is stopped, secretes another hormone called glucagon, which kind of takes out or brings out the storage from the liver and pushes the blood glucose into the bloodstream and bringing the glucose up. So insulin, it either goes up or down depending on the glucose level, and then it's kind of the homeostasis is maintained by the secretion of insulin and other hormones. When this balance gets disrupted, that's when we call it as diabetes. So what happens when this balance gets disrupted? So now, as I said earlier on, the diabetes is all about the sugar being absorbed from the stomach, the insulin being secreted from the pancreas, and both comes to the bloodstream. And you should have normal level of both, and then they get kind of utilized in the peripheral cells. And if there is a deficiency there, you have a problem. If there's a deficiency there, you have a problem. So it's a syndrome characterized by inappropriate hyperglycemia due to deficiency of insulin or combination of insulin resistance. I will explain what that means, and inadequate usage of glucose because of reduced insulin. So that takes us nicely to different types of insulin. So what happens and what are the types of insulin? Basically, there are few types, but mainly what we see is type 1 and type 2. Type 1 diabetes is usually seen in younger people, especially children, and this is primarily the defect of the pancreas. So if you look at the cartoon on the right side, initially there's a picture of pancreas which secretes insulin, and this insulin will go and sit on the receptor in the cell, which opens up the glucose pore, and the glucose goes in, and that's how the normal glucose utilization happens. In type 1 diabetes, there is no secretion of insulin. So the insulin is not secreted. There's a lot of glucose floating around because it's absorbed after you have taken a meal, but the insulin is not there, which goes and sits on the receptor. So therefore the pore does not open, and there is a lot of glucose in the system, in the blood, but the cells don't get it. So it's not utilized, and the body thinks that there isn't enough glucose, and you get into trouble because of that. So here the primary problem is no insulin, and the treatment for type 1 is straightforward insulin, nothing else. So you might have heard some people being on insulin when they're diagnosed young and they're straight on insulin, and this is the case. Type 2 diabetes is slightly different, and this is where most of the people have this. The diabetes, what we see in general population, especially in adults, is type 2 diabetes. What happens here is there is insulin production. In most cases, there is reduced production, but there is still good amount of insulin, and there is also good amount of sugar after you eat. But the insulin, the way it acts on the receptor, there is a defect on that. So doesn't go and always sit on the receptor because it acts like a lock and key, and there is a defect there, and there are various factors affecting it. And therefore, sorry, just need to go back to that slide. Therefore, what happens is the pore does not open. And because the pore does not open, the glucose stays outside. So you have insulin in type 2, you have sugar, but because of the defective system, it's not being utilized. And there are other types of diabetes called gestational diabetes. This is the diabetes that happens in pregnancy. Most of the pregnant people get it. And it's similar to type 2 diabetes, but the pathophysiology is slightly different because there are a lot of hormones that come into play when pregnancy happens. And those hormones also affect these insulin resistance. And that's a different entity, gestational diabetes. Most of the time it resolves after delivery, but it can come back again. And there is another group called monogenic diabetes, which is pure genetic. It's called maturity onset diabetes in young. It behaves slightly differently, but treatment is similar to type 2. Then we have secondary diabetes, secondary by which we mean it's because of the disorder of the pancreas. If the pancreas is taken out, obviously you don't have insulin, then you get diabetes because of that. And there are other hormonal endocrinopathies like increased steroids and other conditions which affects the insulin pathway, and certain medications like steroids and chemotherapy and even infections which affects the pancreas and the insulin metabolism, which can cause diabetes. And one of them recently, even COVID, can impact on the sugar metabolism. And there are case reports of new diabetes being diagnosed after COVID infections. One of the treatment for COVID infection is steroids, which will again have an impact on the sugar as well. So in type 1 diabetes, as I explained, what happens is there's sugar that gets absorbed. There is a lot of sugar in your blood vessels. The insulin secretion is not that great, so you don't have enough insulin. So in normal people, when the insulin comes and attaches to the cell there, the sugar should go in. But with people with type 1 diabetes, you don't have that insulin to come and sit there, which activates the reception and the cascade that happens below that. So the pore does not open, and you have a lot of sugar in the system. That's type 1. In type 2, it's slightly different. You have a lot of sugar, you have a lot of insulin in the system, but it's the working at the cellular level that's defective. So normally when the insulin comes and attaches there, it does not click in properly, and therefore the cascade reaction that happens underneath, it's a big chain of reaction that happens, which eventually results in the opening of the pore does not happen. So some insulin comes and sits there, but nothing happens. So there is knock on the door, but there's nobody inside, there's no opening of the door. And some of the receptors work, and when insulin comes and attaches there, it kickstarts a cascade and then opens the pore and the glucose goes in. So with type 2 diabetes, you have a lot of receptors. Most of them are not functioning. Some of them are functioning. You will need much more insulin that you normally have for the proper functioning. So the medication and treatment around this is mainly to kind of interfere with the system here or take more insulin. Now, what are the other factors in type 2? In type 1, as I said, it's purely because of the problem with the pancreas, and there are antibodies sometimes, by which I mean there are cells in the system that attacks your pancreas, which makes the pancreas to work less. And there is nothing much more you can do physically or personally to prevent that. Whereas in type 2, there are a lot of risk factors which are modifiable and non-modifiable. Some of the things like family history, genetic predisposition, your genes, and your ethnicity, you can't change that. But there are other factors like obesity, physical activity, unhealthy diet, and even your gut microbiome. This is a new topic that's coming into the 21st century, your gut microbiome, the bacteria in the gut that can influence your healthy state and physical condition and other disorders. That is also an important factor. It can change based on what you eat and how you eat, and including your sleep pattern. So all these factors can influence your insulin sensitivity or resistance, the inflammatory state, the gut symbiosis, and your physical activity, your weight, your diet. All these are completely modifiable. Of course, the other factors like mitochondrial function, cellular function, and genetics are beyond your control. So the type 1 and type 2 in brief, type 1 cannot be cured. But what happens is the body does not have enough insulin, and the causes are completely not known, but genetics may play a part. There are infections that's attributed to it, and you need injections for life. That's type 1. Whereas in type 2, this can be prevented up to a certain extent with lifestyle modification, obesity, activity, food control, etc. And your body has insulin. Your body has insulin, but mostly not enough. And the cause, as I said already, genetics plays a part, but there's also obesity and other factors. And you may or may not need insulin depending on the degree of hyperglycemia or high sugar. These are the difference, but both the diabetes can cause problems if not controlled in terms of complication. They both require healthy lifestyle and management in treatment. And the symptoms of hyperglycemia or high glucose is kind of similar in both cases, but it can be a bit more quicker with type 1. So in type 1, what happens is because there is acute or sudden insulin deficiency, you get symptoms happening very quickly. And it's what usually happens to younger people or children. The main symptom is they're always thirsty, they pass a lot of urine, and they are kind of chirpy and running around, but they become very fatigued, tired, listless. They're sleeping most of the day. When they have a cut or injury, it doesn't heal very well, and they become more and more lethargic, just keep drinking a lot of water, passing urine. And these are the symptoms, and if not treated quickly, they can become unwell in insulin. So the trajectory of their symptoms, it's pretty quicker, and it happens quite sooner, and they end up needing insulin quite quickly. In terms of the type 2 diabetes, the symptoms takes a longer path. The symptoms are kind of similar in terms of frequent urination and feeling thirsty all the time. You lose weight as well, and there is poor healing. But this happens over a long time, not just a couple of weeks or months. It can take up to years. And when you look at the diabetes, as I said, 90% of them are type 2 and 10% of the type 1. So most of them are initially treated with tablets. And type 1, the treatment is just insulin, no way around it. And you have insulin pens, and which I'll talk about a bit more in detail later on. And nowadays you also have insulin pumps, which I will talk about later on. So for type 1, the treatment is insulin. With type 2, it's a slightly different approach, and I will quickly discuss about the glucose levels as well, because you might have heard about the Hba1c test. We call it as A1C as well. This is one of the tests that's done for people with diabetes. So if you know somebody who has diabetes or somebody who has got diabetes, they will know a bit more about this. And Hba1c is the test that looks at your red blood cells. Every time your sugar goes up, your red blood cell will accumulate a bit of glucose, and over 3 months' time, that's a time period lifespan of RBC. You look at the amount of glucose aggregated in your RBC, that will tell you how your sugar has been over the last 3 months. And usually an average of 5.6 to 5.7, below that is considered normal. 5.7 to 6.4 is considered as borderline or pre-diabetes, which means you're not normal, you're not diabetic yet, but there is a good chance you will progress that way if you don't make changes. And above 6.5 is where you have diabetes. And there is glucose control kind of corresponding to that, which looks at it. But if we don't kind of go for glucose nowadays to diagnose it, because it can change from day to day, depending on what you eat and what exercise you do. And the glucose tolerance test, this is a test done to confirm diabetes. We don't use this anymore once we have the Hba1c and the glucose better readings. We used to do that before, a long time ago. But we still use this test for people in pregnancy, because diagnosing it earlier on is important, and their insulin resistance to be picked up is important, because it can have an impact. So what we do is we give a bit of glucose solution and check the glucose after 30 minutes and 1 hour to see how the response is. And if it's going above a certain limit, that means they're diagnostic and they have problem with glucose homeostasis. So treatment of type 2 diabetes is slightly different. If it's borderline, the treatment is just diet and exercise, because that can have a huge impact on the glucose and the insulin resistance. If the sugar level is higher, even more, you may need medications to control the sugar. And then if it's more, you will need multiple medications or insulin. So that's the stepwise approach. It's not just a medicine approach. You go from lifestyle to diet to exercise to losing weight to medication, and maybe injections if needed after that. So in type 2 diabetes, the most important factor is diet and exercise and losing weight. The insulin resistance we discussed before, that can change significantly if you lose weight and if you do exercise and lose weight. And the interesting bit is if you do exercise and even if you don't lose weight, you still improve your insulin sensitivity, by which I mean is the amount of insulin that's needed to control the sugar. If your insulin resistance is high, that insulin level is more. So if you do exercise, the amount of the insulin becomes more effective and it can bring down the sugar. It gets locked in more effectively simply by doing exercise and if you don't lose weight. And if you lose weight, the impact is almost double. So now looking at the other treatment options, if you go back and look at the history, what the medication we had was metformin, and it got discovered in 1922. And the first clinical trial was 1952 after 30 years. And the first time it was used was in 57, which is 35 years after this kind of discovery. So if you compare that with the speed at which the COVID vaccine was developed, you can see where SADS has reached now. Within 1 or 2 years, we have got the complete discovery to clinical trial to usage within 2 years. And with metformin, it's taken 35 years. So that's the state what the medical progress was before. And to go back, that's the picture there. On the right side is the picture of my textbook pharmacology page without trying to reveal my age. And if you look at that, there's been very few medications there. And most of that on the list, we don't use anymore. Just a couple of them. Metformin we still use, we still tested and it's still good. And 1 or 2 of these from the second generation we use. The rest all we don't use anymore. It's completely gone. So what I studied in medical school in the 90s is out of date already. We don't use that anymore. And since then, there has been an explosion of newer medications coming in with different activity and different levels. And there are different groups. I'll go a bit briefly on that. I don't want to spend too much time because each section is a talk on its own. We have a lot of subgroups called insulin sensitizers, DPP4 inhibitors, SGLT2, glitazars, quite a few groups and injections that's coming in as well, which all happened in the last 20 years or 15 years. And diabetes has changed big time. The management has changed big time in the last 15 to 20 years. So how do they work? Just without going in depth, the thiazolidone group, the first medication which was discovered was troglitazone, which is not used anymore. Rosiglitazone, there were a lot of issues some of you might have heard. We have stopped using that. And the only medication used is pioglitazone. You might have heard, some of you might have heard about that. It's called Actos in the market. It works mainly in the periphery with making the insulin more sensitive, works in the muscles, works with the uptake of sugar in the liver and also in the fat. So it helps to reduce the fat as well. So it makes insulin more sensitive. The second group of is DPP4 inhibitors. What it means is, as I've said earlier in the other chart with the metabolism, there are a lot of other hormones that get secreted. And one of them is GLP. I don't know if anyone's mic is on. Hello, can you hear me?
Yeah, we can hear you. Yes.
Yeah, some disturbance is there.
There are other hormones that get secreted with insulin, especially GLP-1 and GIP-1, which kind of interferes with the stomach clearance, sugar maintenance, and these hormones are not secreted very effectively in people with diabetes, and when they're secreted, they're in minimal amounts and they get broken down very quickly. And they are broken down by an enzyme called DPP4. So what these tablets do is they block the action of DPP4. So the minimal amount of hormones that is secreted, it acts for longer, and they have the better effect on the glucose. So there are quite a few medications in that group. Just put the names all there just for kind of to familiarize in case you want to have a look. The next group is SGLT2. This is again a new kid on the block. They work mainly on the kidneys. If you look at the picture on the right, the cut section of the kidney there, you have these filtering mechanism there for the kidneys called nephrons, and they filter, and the urine comes down and it comes down to the tube in the urine and it goes down there. So if you take a cut section of that, this is how it looks like. It's a nephron, it's a filtering system, and this is the pictogram of that. It's one of the most effective filtering system in the world up so far, to be honest. The blood goes in there, it gets filtered, all the toxic materials, including everything, including sugar, everything gets filtered through there. And depending on what the body needs, it gets reabsorbed in these various parts, some of the minerals and the Even glucose gets reabsorbed from there, the water gets reabsorbed from there, other calcium and everything gets reabsorbed from there. So whatever the body needs, it will get reabsorbed through that, and the rest, the waste, will go throughout as urine, and it gets collected in the collecting tubule and goes down. And you have millions of this in each kidney, and you have 2 kidneys. So where this works is this group of tablets works here, and it prevents the reabsorption of the glucose. So the glucose just goes out into the urine, and the sugar in the blood comes down. And there have been a lot of studies which is kind of proven to be beneficial in the kidneys, heart, and also the blood vessels, and along with other body weight as well. And these medications have been now shown to be effective in cardiac failures, heart failures, and Dr. Siraj mentioned cardiologists are using this more often as well. So this is found to be beneficial for the kidneys, the heart, as well as the diabetes. Now we look at the injections. This is the injection for type 2 people with type 2 diabetes. These are fairly new as well. It's not insulin, and this helps a bit more with sugar control. And if you look at the right side, I put a picture of a lizard there. It's a Gila monster lizard, which is a poisonous lizard in America. The reason I put there is this medicine was actually developed from the saliva of this monster. The reason why they found this out was this lizard only eats once in a year. They eats in the springtime, and it can eat up to 1/3 to almost his body weight during that time, and it doesn't eat for the rest of the year. So the scientists were intrigued. How do they maintain the metabolism when they eat only once a year? And there were a lot of hormones that helps it to survive that. And one of them is a glucopeptide, which is called exendin. And that has an impact on the stomach, the body weight, the brains, where your hunger center, and which kind of they developed it to use it for diabetes, because the effect is brilliant. It reduces the motility of the stomach, keeping the food longer, so your sugar does not get absorbed quicker and the sugar does not go up quicker. It also increases the other hormones that we discussed earlier about metabolism, making the sugar metabolism more effective. It increases the insulin, helps the pancreas as well, and it works on your hunger center, making you less hungry. So the effect is quite impressive. And initially it was an exenatide one, which was twice daily injection. That's not in the market anymore in our part of the world. Some parts, I think they still use it, because most of the time they use now once daily injection. And now they have come up with once weekly injection as well. This is a similar long-acting, slightly modified molecule, which you inject once weekly. And the effect is actually brilliant. It acts on the stomach. As we said, it reduces the gastric emptying, so food stays there longer. It works on the brain center, and it suppresses your appetite, and you're not hungry anymore. It has got positive effect on the heart and the kidney, sugar uptake in the periphery. It reduces weight significantly, brings down the fat. It has an impact on the liver metabolism, and it also increases the insulin secretion. And on top of that, the beta cell, that is a cell that is in the pancreas that secretes insulin. Beta cell, actually, your function of the beta cell comes down with year, especially in people with diabetes. So you have less and less functioning beta cell. And this medication actually promotes the survival, and hence making the progression of diabetes very slow. So all in all, an impressive medication. And this is the injectable medication used in type 2 diabetes before we go on to insulin. And if that also fails, then the next thing is insulin. Whereas in type 1, the first step is insulin. In type 2, you end up on insulin when all these doesn't work. And insulin has come a long way as well. Previously, it was just in vial with a syringe. You have to put the syringe in there, take out the insulin based on your requirement, the dosing, and then inject it. It used to come in vial. Then it changed to a pen with cartridges. You have to put the cartridges in, apply the needle here, and then dial the required dose you need there, and then press it. And now it's progressed to just pen. It's insulin built in, and it's like a pen. You can put in your pocket and walk away. And you just open it, put the needle in, and then dial your insulin to wherever your requirement is, and then inject it, put it back in your pocket, and walk away. So there are different types of insulin depending on their requirement. We just adjust it based on what the level is. There are very short-acting insulin to intermediate acting to very long-acting, and some of the injections can last for full 24 hours. So now there is also a combination of both the GLP-1, which I was talking about, the injection for the type 2 diabetes, and the insulin. And you get in the market, it's called as Zyltephy or Soliqua, which has got a bit of both insulin and GLP-1, which is, we got the best of the both worlds. Insulin is better at controlling the sugar in the morning, whereas GLP-1 is good at controlling sugar after food. So combining both, you get the best of both worlds. It can be slightly costlier than the other one, but it's very effective, and it's only one injection instead of 2-3 injections. So coming back to the HbA1c, we have talked about HbA1c, what it is. It is an indicator of blood sugar level. And if you look at the pictogram and the heat gradient across it, what it means is it's green here, 6 to 7%, that control is good. 5 is normal. And with people with diabetes, we try and keep the control there between 6 and 7, which is good control. The reason why we say good control is it prevents the risk of having complication. Your risk of complication goes up as your HbA1c goes above 7.5. Gradually, as the level goes up, it goes hotter and hotter because the risk of complication almost doubles. And what are the complications? Major complications, there are 2 types, microvascular and macrovascular, what we call it as, essentially means small vessels and big vessels. It can affect the big vessels, and then it affects the organ supplied by the big vessels. That's the brain, heart, and the leg. As somebody was already talking about foot amputations, this is because of the effect on the big vessels, and again, heart problems, heart attacks, and strokes. What you commonly don't see is small vessel complications, which is affecting the eye, the kidney, and neuropathy. These are quite silent, and you don't get it, you don't find it out unless you test for it. And I will go a bit more, I'll explain a bit more on the microvascular. So everybody with diabetes usually should have their eyes tested at least once. What we look at is behind the eye, in the retina, back of the eye. And this is what the picture looks like on the right. You have the optic disc there through which the blood vessels and the optic nerve comes out, and the optic vessel supplies the whole of the retina. And you have this area where it's called fovea and the macula, where most of the color cells are, and that's the most sensitive area, or the important area as far as your eyesight is concerned. So this is the normal picture of a retina. With diabetes, what happens is you have reduced blood supply to the, because of it can impact on the small vessels of the retina. And then you have, if you look at the vessels as well, if I can go back to the previous slide, you might remember the blood vessels were a bit more straightforward, and here it's a bit tortuous. And what happens is you get small bleeding there. I don't know if you can appreciate that. You can see it's very small bleed there. This is very mild change, and usually if you improve the control, get the blood pressure right, this will get better on its own. This doesn't need any treatment. But as the disease progresses, or if the sugar is uncontrolled, you get more and more bleeds. You can see more and more dots there. And importantly, you can, if you have dots or bleeds near this fovea or macula, it gets more serious because it can have an impact on your vision. And the more severe it gets, there is an edema around the optic disc, which can affect the optic nerve and the blood supply. And you also have multiple bleeding spots with reduced blood supply. And in severe form, you will have small blood vessels growing there around the eyes, which shows severe lack of blood supply to the retina, and there is growth of small blood vessels. This, when it comes to this area, it can have a serious impact on the eyesight and with potential risk of losing eyesight. So we try to treat the glucose before it gets to this stage. And this is important that you get your eye checked at least once a year.
Excuse me,
Sure.
doctor. Doctor, I think your power is less, the connection. I think you might have to charge it. Yeah. It's showing.
Is it? Okay, thank you. Thanks for telling me that the plug was off.
Carry on, Ken.
Okay, thanks for that. Now, going back to that is a severe form of retinopathy. When it gets, what happens is sometimes you can have, when it gets severe, you can have big bleed into the back of the retina. And that's how it looks like. It's major bleeding there. And it needs to be treated. It's an emergency, because if you don't treat that quickly, you can lose your eyesight. And there are different types of treatment. One of the treatment is phototherapy, photocoagulation. That is also done for other retinal disease of the eyes. And it can go up to surgery in certain cases. So what happens there is, if you look at the 3 pictures on the side, this is a retinal bleed there. And if you look at the OCT, this is a CT of the eyes on the lateral side. If you see, that's the retina there. This is the eyeball at the back, and there is bleeding there. So the whole thing is pushed up, and there is a lot of blood in the background. And once you treat that with phototherapy, it gets better, and it's almost resolved in the third picture. So it's much better. But if you look on this side, there is scars of the phototherapy there, but there's still more ischemic changes there, still more to do with the glucose control and blood pressure control and cholesterol control. And the next is the kidneys. So with kidneys, there is nothing much to see for the naked eye. It's mainly for the what you see is in the blood test in terms of the protein and the kidney functions. What happens is the same nephrons, what we were talking about, hyperglycemia or high sugar for a long time can affect the filtering system. And the defective filter can, initially how it's shown is there is increased filtering of the protein. So you lose a lot of protein in your urine. And if you might have heard people with diabetes or someone who you know diabetes hearing that they have got protein in the urine. That's the first stage. It starts with protein in the urine, which means the diabetes is affecting the kidney, time to get the control right, time to get the blood pressure right. And as the kidney function progresses, it can go to 1, 2, 3, 4, or 5, where the kidney function is around 100% to 80% to 50% in stage 3. And it can gradually go down to less than 15% in stage 5, and then later on they might end up on dialysis. Now, the important thing is that once the kidney function deteriorates, there is no going back. It doesn't usually get better, even if you improve the control. But the good news is if you can improve the control and the blood pressure, it stops further prevention or deterioration. So if your kidney is in stage 3A and you decide to get your control better, your sugar better, your cholesterol better, decide to lose weight, then the progression from 3A to 3B to 4 will be much, much slower. Sometimes you will not be able to prevent it completely, but you can deliberately and definitely stop the progression, and in some cases you can even prevent the progression, which is really good. And with regards to peripheral neuropathy, this is mainly to affect with the nerves, and people who are having diabetes, they also need to have their foot examined in terms of sensation and blood supply at least once a year. What essentially happens is the very, very small vessels that applies the very small nerves, they get damaged, which effectively kind of affect the nerves, and then you have reduced sensation of the leg, which has got serious impact because people will not know when they have a cut or a wound, and they can get infected. And if the blood supply is reduced, it can lead to big infections affecting the survival of the feet. So it's important they check the sensation every year. And again, the sensation, once the damage is done, it's very difficult to improve, but you can prevent further progression if you find it out and improve your control. So in terms of the major vessel disease, this is something which most of you have seen or heard of other people having. It affects the big vessels as well, big blood vessels. So there is a blood vessel, if you take a cut section, there is a muscular layer and there is an inner layer called endothelium. There's a layer of cells which is constantly repairing itself. And with people with diabetes, they have endothelial dysfunction. They don't kind of repair it very well, and sometimes they can have damage to it. And when they have damage to it, because of the increased inflammatory reaction, they tend to get bigger and bigger with deposition of fat. And if you have a high cholesterol, that's another factor which makes the plaque bigger and bigger till it gets blocked. And once it's blocked, it simply causes what we call as heart attack, or in brain strokes, and in leg, severe acute loss of blood supply to the leg. And that's what you probably see when they have heart attack. They put a stent in and they open up. So this is also something that can be prevented or decreased up to a certain extent by improving the control, blood pressure, and the cholesterol. So where are we with diabetes? I think we have kind of said how we have progressed, how well we are doing with management, our discoveries, our injections, etc., etc. So we should be doing really well. We should be patting on our back. But are we really doing well? If we look at the diabetes and the treatment and the control, how we are doing, this is, on the left is a European study which shows only 31% of the people actually have got good control around the world, in spite of all these newer medications, injections, newer technology, etc., etc. And 2/3 of the people with type 2 diabetes haven't even got a good control, so they are still at risk. So what is wrong? So are we doing right? probably not. And there are a lot of factors for this. That is inertia, reluctance to change it, lack of lifestyle modification, and not wanting to see doctor and not wanting to take medication. A lot of factors to that. And also increase in kind of life survival rate. People are living longer with diabetes. Now, what does the future look like? If you look at this map, this is the kind of, it shows the number of people with diabetes around the world. And this is what we have, 382 million. But by 2035, the expected growth rate is going to be 592 million, increase of 55%. That's how exponentially diabetes is going up. And if you look at the countries, Southeast Asia and MENA, the prevalence of diabetes, people with diabetes in our area, in the GCC MENA area, it's quite high. And if you look at the gestational diabetes, one of the highest rates is in Southeast Asia. So this is the heat map on this side showing from 2015 to 2035. And the area in red has got the highest diabetes, yellow less than that, blue less than that, and green even less. And if you go through it over the years, see what's happening, the yellow and green is actually disappearing, and you get more and more red countries. More and more people are having diabetes. So the diabetes control is not being good. The diabetes, people with diabetes numbers are increasing exponentially. And if you look at a bit more in India, what's happening? Can you mute your mic, please? Hello? Okay. Can you hear me? Hello?
Yes.
Yeah.
Yes.
And if you look at the diabetes state in India, in 2019, we are the second highest in the number of diabetes patients. So it's like 75 million. And if you look at the population as 100 crore or 110 crore, that's like 7.5 crore of that people with diabetes. That's quite high number. And if you look at the heat map of India, if you look the way down, you don't need me to explain that. It looks pretty red down Kerala, Karnataka area. That's more than 10.5 prevalence. That is, if you take 10 people, one of them will have diabetes in Kerala. And the way it's projected to increase by 55% by another 10 years, 15 years, every 6 to 7 people you take, one of them will have a diabetes. That's essentially a big family. 5 or 6 people, one of them will have diabetes. That's the extent of the growth. And why is it happening? It's type 2 diabetes. This is the biggest growth. And as I said earlier, there are modifiable and non-modifiable factors. Of course, we can't change our genes. We can't change our age. We can't change our ethnicity. But there are other factors which we can definitely modify, especially physical activity, your body weight, obesity, your metabolic factors. Most of them simply says diabetes runs in the family, and simply that's because nobody else runs in the family, I feel. And there are a lot of changes you can make. And that's what I think we need to concentrate on. If you look at the growth of predicted growth of diabetes in 2040, both in men and women, it's kind of going to be double. So there is no difference between men and women. Both are going to have double the risk. And the other interesting factor is who is at risk of having this. This is the change of diabetes predicted in rural areas based on the growth, and this is in the urban area. If you look at the rural area, the change is very minimal. If you look at the urban area, in 20 years, it's going to be double. So why is that? It's simply because we don't move much. We don't do much exercise. We have gone to kind of using car and train and all kind of transport. And the food, the diet has changed. Minimal activity, most of the time in front of games or TV. So it's very sedentary lifestyle with significant change in dietary habits, a lot of junk food and minimal movement. Whereas in villages, it's still, the lifestyle is not that very different. I'm not asking everybody to move to villages, but I think that we need to look at the lifestyle and probably change our urban lifestyle and probably be more active and less sedentary, which will make a big difference. And I think this is what we need to do. Because, and it's not just prediction. If you look at the study, the diabetes prevention program study that happened in the States, what they did was all the people with pre-diabetes, they put into 3 groups. One of them, they did nothing and observed. The second group, they gave metformin, a tablet. And the third group, they went to aggressive lifestyle management, with food change, diet, healthy diet, and exercise with a way to lose weight. And if you look at the graph there, the three groups, the 25 to 40, 45 to 50, and 60 above 60, the weight reduction, that the red group is the lifestyle management. It's up to 50% of decreased risk of developing diabetes in the younger group, 60% in the middle-aged group, and 70% in the elderly group. So no matter what age group you're in, across the board, there is significant reduction in the risk of developing diabetes simply by doing lifestyle change. So I think there is a clear message there. We have got a lot of new medication, a lot of new developments, a lot of new injections, but the fact still lies, the most important factor is lifestyle and weight. And this is what we need to concentrate on. And there are a lot of barriers to it. Of course, obesity, it's not considered negatively from where I come from, and you know that. If you're obese, you're kind of called as healthy, and if you're lean, you're called as unhealthy, which is probably not the right approach. And the fat food culture, we are all moving towards junk food more, and changing diet. Of course, it's very difficult. With we are used to high carb diet, and that's the diet meant for people who work very hard. I mean, if you go back to how lifestyle was back in Kerala 20, 30 years ago, they were fairly active. They were working in the field, paddy fields mainly, those people who were eating high carb food, and they burn all the energy. But nowadays we stick to the same diet, but we don't burn it. So they just accumulate. And there is very minimal value given to physical exercise. I have to say this approach is changing, and which is a good sign, especially in southern India and Kerala and Middle East. People are giving more importance to physical exercise nowadays, which is quite good. And this is something I hear in my clinic as well, no time for physical exercise because of the work and hectic lifestyle. And what I usually tell them is, if you don't find time for yourself, your body will force you to find time for yourself later on. So this is something that has to be incorporated in your life. And fatalism as well. I know it's good to have a faith, but people tend to blame everything on the God. I mean, there are some things that you can't control. There are most of the things that comes your way, you cannot change it. But there are things that you can do in terms of improving your lifestyle, especially your weight, your food habits, your exercise, without blaming fate. I think we need to take responsibility for a bit more. So that's where before I conclude, I would probably talk a bit more on the technology as well, because no talk is complete without technology. I'm aware of the time. I'll just quickly whiz through the technology in diabetes. You all know the glucose meter that we use, and now it's being progressed. You have all-in-one with the needle and the strips inside. With one click, you get everything. And now you also have the glucose meter attached to your phone, where you check it, and all the results comes as a graph onto your phone. These are all with blood glucose machines, which have been there for some time. And then this is something that is coming into the market. You're getting what do you call a lens, which I think Google is also investing in that, which reads your blood glucose, and the reading is kind of sent to your phone, smartwatch. Still not in the market. What is in the market is this one, which is sensors. And you attach this sensor to your hand, which can record glucose continuously. And it can store glucose readings up to 8 hours. So all you need to do is you have that reader, and even if you put your dress back on, you just simply swipe that reader on that, even on top of your dress. All you need to do is swipe it on that. This sensor stays on your arm for 2 weeks. Every 2 weeks you change it, and you get a reading there. And if you do it every 8 hours, you get a full 24 hours reading on that. And when they come to clinic, we download that. And nowadays we have the software to do it on the mobile, so they don't even need to carry a glucose meter or a reader. Simply put the sensor on for 2 weeks and keep checking with your mobile. And then you come to clinic, we download that, we see what's happening to the sugar, the variation through the day on a daily basis. There is some 7 to 8 pages of this, and we can individually go through every day of the week. And nowadays with COVID and remote clinic, we are even doing it online. They go into the website, they upload it, we download it from the clinic, look at it, speak to them over phone and tell them where to increase the insulin. For example, the sugar is going up there, we adjust the insulin there. If it's going too low, we reduce it there, we look at it. So we can actually do it remotely. Of course, appointment is still important, but we do this more often. They don't need to come every 2-3 weeks or every month, and we can do this quite easily from our clinic when they upload it into the system. And insulin pump, this was the first insulin pump that was built years ago. And then that has progressed and the size has come down. And then this is where we are now. You have a pump there with a reservoir, get insulin there through this tube, it goes in there and there is a continuous insulin going. We can adjust the rate at which it goes depending on your activity. And every time you eat food, we can adjust it with this remote. You just put how much insulin you want to give on this remote and click it. And it's remotely tells the pump to deliver it, and it delivers that. And this is the glucose sensor, which senses the glucose and tells you what your glucose level is. And now we have more advanced pump where they talk to each other. The sensor, if the sugar is too low, it will tell the pump to stop and it will stop giving insulin. If it's high, it will increase it a little bit. But still you have to do, when you eat food, you have to give more that you can do with your remote control. You don't even need to touch the pump. So you have the delivery system there, the reservoir and the pump there, and the sensor there, they're all talking to each other. That's the latest pump, which is kind of called artificial pancreas. It's not similar to pancreas, but almost there. And you have some kind of fancy pumps for the kids. And obviously you might have heard about the pancreatic transplant, where the whole pancreas is transplant. And the new thing that's happening is the islet cell transplant. What happens is islet cells are the cells that produces the insulin in the pancreas. You take the pancreas out and you just take it through a filter and just take the islet cell that is to do with the insulin. You inject them into the vein below the liver. You don't need a surgery for this, so you just inject it and these cells go and sit inside the liver where they get enough blood supply, and that's it, they start secreting the insulin based on the glucose. So it's similar to pancreas, but no surgery, no need of whole pancreas, just the islet cell that comes into the liver. It's not as, the success rate is not as good as pancreas, but I'm sure it will improve as we go. So again, coming back to the same story, we have got a lot of technology, we have got a lot of advances, but still the basic remains the same. It's all about diet, exercise, lifestyle, weight, and improving your risk. Prevention is better than cure. So I'll stop there and open for any questions.
Thank you very much, Dr. Sajid. It was quite a session from you, a lot of information, and I think some things probably not understood also very well because we are not from that medical background. But since this has been recorded, surely we can go back and understand it better. Let me invite Dr. Abdul Nasir to open up for the question answers. Dr. Abdul Nasir, are you there? He was telling he was held up with some conference 15 minutes back. He sent a message.
Right. Okay.
Yeah.
Sorry, I tried to make it a kind of a mixture for everybody attending. So if some things have gone above your head, I do apologize. I'm happy to clarify.
Okay, that's okay, no problem. But still a lot of good information anyway. Also, it was interesting to note the technological advancement, you know. Anyway, Dr. Abdul Nasir, I think he's still stuck with other programs. Okay, another conference, yeah. So anybody, is there any questions you wanted to be cleared, please open up here. The platform is open.
Yeah, Dr. Sajid, I have a question.
Yes.
Why do you think the number of dialysis cases has grown so phenomenally high these days?
A combination of features, to be honest. I think what's happened is everything has gone up, to be honest. The number of diabetes cases have gone up. The number of people who are not controlled for diabetes has gone up. The number of complications with renal dialysis has gone up, and retinal complications have gone up. The only thing that hasn't significantly gone up or come down is the cardiac complications. I think hats off a bit to cardiologists as well in that aspect. They have been more aggressive with regards to primary and secondary prevention and intervention. Other than that, everything has gone up. And the factor, to be precise, for dialysis is, one, people are living longer, much longer than before. People with complications didn't live this long. And people on dialysis, when they had so many multiple comorbidities and they didn't do very well before. But now the intervention from the cardiology side and the dialysis side, and even people on dialysis, they didn't live very long in the past because the complications of dialysis itself was pretty poor. And the survival on dialysis was very minimal, and that's why still it's not good. That's why they try and get on to on the transplant list, because their survival rate goes up. So the survival was never good anyway, but because of the increased population of diabetes, because of the longer duration of the diabetes, and before the people on dialysis live longer and they survive longer, then there's a combination of factors that kind of makes it makes more people on dialysis, I feel.
Thank you so much, Dr. Sajid.
Yeah, Mr. Sadiq Ali has a question, I think. Sadiq Ali?
Yeah, Assalamu alaikum, doctor.
Wa alaikum salam.
I have been diabetes for almost 2 decades.
Okay.
Until last year, before having COVID, I was under medication like Forxiga and Amaryl.
Okay.
It was in control. But during a pandemic, my diabetes was going up to 16 to 20 while I was admitted in the hospital. Since then, they recommended to have insulin, Lantus,
Okay.
only for afternoon. Now what happened, I'm taking the Lantus after evening. By 8 o'clock, I go for a walk, and when I come back, my sugar is much lower, even below 5. Sometime when I check my BP also going to lower level. I used to have 140 or 130 plus, bar 80. A couple of times I noticed that it was going 80 to 60 kind of BP level. After, especially after this COVID time, also after having a vaccination Pfizer, I am facing some difficulties. This is related to the COVID, related to my vaccination. And can you tell me what is the situation now? Why it's happening?
Okay. Can I ask how long has it been since you have had COVID?
Yeah, I have been admitted in the hospital last year,
When?
same period, 8 days. Last year, same period.
1 year. It's been 1 year.
1
Okay.
year now, yeah.
Okay. Okay. Now, again, understanding of the COVID and diabetes have changed in the last 1 year. Before, when anybody with COVID who takes Forxiga gets admitted, used to stop that period because it was thought to be ketone producing, and it's not good for people with diabetes. But now that concept is changing. There is new evidence that it's not bad. Now, Forxiga is a very good medication, which has got a lot of good effects. And people, what we do now is we don't stop it unless they are very, very unwell. And even if you stop it, you restart it after you get better. That's one factor, because it's much better in terms of controlling the sugar, the weight, and the fluctuation. Now, I'm not sure whether you have been back on it after the discharge, or are you still on insulin or not on any medication?
I'm continuing the insulin because I feel it's very comfortable. Sugar is not going more than what I should say, maximum 8.
Okay. Are you taking those tablets, or has that been stopped?
Forxiga is still continuing for the afternoon. The morning I'm getting Amaryl point, 5 milli.
Okay. Now,
Yeah.
if you remember my slide that I've showed with the insulin, there are some insulin that works for 2 hours, 4 hours, 8 hours, and some 24 hours. Lantus is one of those that works for 24 hours. So it will have the same effect all over during the day for 24 hours. So if you burn more during a certain time, you will have a low sugar. If you eat more, you will have a high sugar. Lantus doesn't control that because it's a steady control over 24 hours. So if you're having issues after exercise, I think on the whole, what you need to do is you need to balance it with lifestyle with regards to exercise, diet, food, sugar at the other time, and decrease the Lantus as a whole. Or you will need to find something else when you decrease the insulin completely. And if the sugar goes higher after food some other time, you need to find an alternate solution in terms of dietary change or short-acting medication or short-acting insulin at that time. Very difficult to give a complete overview of the kind of management without knowing the full story. You know what I mean? I'm just giving you a rough overview of what can be done. With regards to fluctuation in blood pressure change, we see that quite often after COVID infection. And some people get better. I've had people who's been on blood pressure tablets for years, and after COVID, their blood pressure dropped and they have come off medicine for a year and they didn't need it after that. We don't completely understand why, and they're still off medication. And there are some other people who had high blood pressure as well. It's not completely understood. Hopefully time will answer that. But there has been cases with fluctuation. And I think it's because of the COVID rather than anything else.
I think you rightly said. I was having Micardis for BP until my vaccination time. The second day of the vaccination, my BP came down. I called my doctor. He said, stop having the Micardis 40 mg. Just have a Concord 2.5. Where I used to be a blood pressure patient, but after vaccination, I never took Micardis or any major BP tablet, which is, I was telling you, it was dropping. Instead of maintaining, even it was dropping. Then my doctor said, before going for the walk, make sure you don't go empty stomach. You make sure to have some water, maybe body getting dehydrated. So better to have some food and water before going for walk. Myself, last 20 years, I'm maintaining my weight, 70 to 73 kg, whatever. Never goes up and down unless until I travel a lot, I eat and all. The maintaining of the weight, walking weekly at least 5 days. Normally I go for even 6-7 days. At least 5 days walking and food. These three things are giving me a very positive result. What you have shown your slides, I always suggest or recommend my friends to do these things. Walk well, maintain your weight, the diet. These are things, it's really helping me. So I am giving tips to others.
Absolutely, that's the way forward.
Thank you very much. It was very informative presentation.
Thank you.
What is the one more question about the BP going low? But last couple of days it is okay. It's not going low. What could be the main reason? What test I have to do?
There are a few reasons. Obviously, dehydration could be one of the reasons, but you can't have that all the time. Sometimes when you go out in a hot day, that can happen. But more than that, there are various other factors that we think the COVID affects, because it's the vascular tone, your blood vessels. When you stand up, your blood vessel constricts and your blood pressure goes up. That's how it maintains it. And there are few studies that shows that it can affect the vascular tone. It can affect the peripheral innervation, how the vessels are controlled. So there are a lot of physiological changes which is not completely understood, that still kind of people are exploring. With regards to the cardiac tone, the cardiac contractility, the vascular tone, that can have impact on the blood pressure. So what we see normally is, as the COVID resolves, it takes a long time for it to resolve. And once you start your diet, your exercise, and you get back to normality, your blood pressure might go back up again. So we are still telling those patients who have come off it, be careful, keep monitoring, it might come back, because these are usually the post-infective changes that happen are transient. It will recover.
Do you suggest me to see a cardio or no need?
Well, if things are stable, of course you can see if you want to, by all means, if that gives you a bit of what you call, if you're a bit concerned, or it gives you a bit of comfort. But considering, listening to what the issues now are, and if it's getting better, it should continue to get better. I don't know if you had seen a cardiologist and had an echo, a look at the heart to see how your heart. Probably worth getting just a cardiology consultation to see how good your heart is, how the pumping is, because there's a lot of issues post-COVID where people have what they call as inflammation around the heart that can affect.
Got it.
Yeah, so it's worth getting. Probably Dr. Suraj can talk about that.
Yeah, just like myocarditis or pericarditis, what we used to see in many patients post-COVID, and we had many patients coming these days. And there is another symptom called like post-COVID long syndrome, and this is like 12 weeks. These patients with COVID they have this symptom like fatigue, shortness of breath, all these things you can feel in all these patients mainly. And just we usually recommend like post-COVID, like CT after 3 months and an echo to see any inflammation or anything. And
thank you very much.
By the way, you are speaking about your low blood pressure. Maybe you are taking medicine and you are control more on the like lifestyle modification. Maybe you have to change your like tablets. Or doctor with you have to come down or some, you know.
I will meet the doctor, my regular doctor. I will be meeting him. I will give him
Yeah.
these comments.
Okay, just to see what's the tablet he is taking, and just you can check. There is another way like called ambulatory BP, or you can check your blood pressure regularly, like 3 days continuously for 3 days, and to see him and to get the readings and to show him what are the readings, and one in the morning, one in the afternoon, one in the night, and so that he can compare and he can go for if we need more like ambulatory BP or something like that, so that he can advise you.
And we are running short of time. Maybe it's time to wind up. Jakku?
Yeah, please. I think.
Thank you. Thank you.
Can I ask a question?
Yeah. Last question. Yeah, please.
Okay, it's for Dr. Sajid. Dr. Sajid, actually, I was reading a report a couple of days back. Like, you know, it is about the pharma companies who have reduced the kind of tolerance level on the sugar level. So now what the report said is that shortly they will be revising it. In a sense, it was just to push in most of the diabetes medicines or something like that. Is there any truth in it, or it's just out of, you know, someone's fantasy?
Right. Okay. One more person from MES, I think. A lot of people.
Yeah, sure.
Right. I think to get your question right, what you're saying is there has been changes in terms of diagnosis of diabetes, and the pharma companies are pushing it to bring it down to push more medications. Is that right? Is that
Yep.
what your question is? Okay.
Exactly.
Well, no, is the short answer. But what I would say is what we usually traditionally did was there was a cutoff for a sugar, and there was a cutoff for diabetes and Hba1c and sugar. And that's what we did. The Americans and the English did the study, and we took it over, and we just kind of kept that as our target. But actually, that's not right. When you look at the increased risk of diabetes, the Southeast Asians have got a completely different makeup in terms of the genetic makeup, adiposity, and the risk factor for diabetes. So what has happened is we didn't do much research and studies from the Southeast Asia. So our risk, for example, BMI, when we look at the BMI, your height versus weight ratio, the normal BMI is 20 to 25. That's above 20 to above 25 is overweight. But this is for Western standards because their obesity is not centripetal. They put weight everywhere. But if you look at Southeast Asians, you have centripetal obesity. You put weight on the abdominal area, which is the metabolic component of that adipose tissue is quite high. Your risk of having heart problems and diabetes is much higher. So your obesity at 25, you're actually much higher risk compared to a Western person. So their 21 to 25 is actually not good for people in Southeast Asia. And they're changing it now. It's 21 to 23 for Southeast Asia. Similarly, the risk with diabetes, your sugar for 105 or 101 is okay for people with person with a Western standard, but it's different for Southeast Asia. So what they're doing is as more and more people are involving in research and more data coming out, people are changing and adapting readings to their own ethnicity and people in their own background. That's why the change is happening. I don't think it's anything to do with the drug company.
Thank you.
You're welcome.
Thank you very much. I think so. The biggest takeaway is, you know, to have a healthy diet and do proper exercises, right, to avoid these kind of disease. Okay, time's running out. Let me ask Mr. Shabir to please wind up the session.
Okay, starting with Dr. Sajid. It was a very informative session. You covered really a lot of areas, right from the course, the treatment, the symptoms, the complications, the technology. It is fantastic in terms of the coverage. You have covered almost all the areas. And in spite of the busy schedule and some other activities, some of our members always took the pain to join the session from the beginning to the end. Let me thank them all from the bottom of my heart for making it. They have a valuable time and presence here, inshallah. Thank you so much, Dr. Sajid, and all the participants who took their time for this valuable session. Thank you so much.